If it works for everyone, we'll get started. We do have a very full agenda and a panel of experts awaiting to share their knowledge and experience with you on the very important topic of justice, equity, diversity, and inclusion. Good evening, everyone. I hope you all had a wonderful week. Happy Friday Eve, as we've been saying. Welcome to the inaugural virtual panel for CAHL Virtual Series 2020. This is the first in a series of 8 sessions that we will be hosting. All of our sessions will be 5:30 to 7 p.m. Pacific Standard Time, and you will be granted face-to-face credits for each of these sessions. Tonight's, however, is 1.5 qualifying education credits, and so those are self-reported on your My CAHL website. We'll also have 2 Learning from Leaders sessions happening, as well as and the annual awards ceremony, which we've also decided to take virtual, as a way of protecting yourself and us during this unprecedented time. Throughout the discussion, the participants will be muted. Our panelists will be able to chime in as they wish. We'll be accepting questions throughout the discussion and addressing questions as we go. So please submit your questions via the chat box. I'd like to give a special thank you to our platinum sponsors, without whom this virtual conference would not be possible. And to whet your appetite, here are the upcoming virtual events we have planned for the remainder of the year. These dates, as well as topics and our panelists, are also available on our CAHL Congress website. You can find that at ache-cahl.org/Congress. Today, the American Nurses Association is launching this wonderful campaign that CAHL is very proud to support. This is the Mask Up campaign. And if you're not already muted, please mute yourselves. Thank you so much. It's the Mask Up campaign with the ongoing spread of COVID-19 and the detrimental impact that has had across our communities. ANA, American Nurses Association, felt it was very important to begin utilizing social media platforms and face-to-face communication where that's possible to spread the word that masking is still something we all must do and must support. And so we encourage you to take photographs of yourselves with your mask on and post them on your social media outlets in your network with the hashtag Mask Up and hashtag CAHL so we can find you. We'll be featuring the photographs of our members on our website throughout the campaign. Here are some of the images that you will see. This is the one that comes from the American Nurse Association. Here's one that comes from CAHL, and another one that you will see on our CAHL social media outlets as well. Before we get started, I would like to, actually we are ready to get started. I'd like to introduce and welcome to the stage Luis Fonseca, COO at Alameda Medical System, to introduce our moderator. Luis, are you able to unmute yourself?
Yes. Well, thank you, Sarah, and good evening, everyone. I am so pleased to see that we've got a large number of participants, 94 participants thus far. So thank you all for taking time in your early evening, late afternoon to join us for this very important topic. I am extremely excited about this as not only having the privilege to serve as our region at large for District 5 for ACHE, but also the chair of the Diversity and Inclusion Committee for CAHL. I love to be first, and I'm glad that we're the first and inaugural face-to-face panel here. So this is how we roll in the D&I committee. And so I want to thank all of you for joining us. It has been a very interesting first half of the year. And I think we have all learned a lot. We have seen a lot. We have had to deal with many different issues. all of which are very relevant to the topics and the discussion that we'll be having tonight. And so, again, I appreciate the time. I'm very pleased to introduce our moderator tonight, who is also a member of our D&I committee. But that's just one of the things that she does in all of her busy time. But I'd like to introduce Ida Bezabeh, who is currently the Manager of Business Consulting at the Permanente Medical Group with Kaiser Permanente. But she also is an Assistant Clinical Professor at the UCSF Department of Community Health Systems. She is the President of Women Healthcare Executives and a member of the D&I committee, as I mentioned. She also founded We Flourish, a wellness community to inspire wellness of the mind, body, and spirit. Ida was named in 2018 40 under 40 by the Silicon Valley Business Journal. And in 2019, in our annual awards ceremony of last year, received the Early Careerist Healthcare Executive Regents Award for our chapter. She holds a bachelor's degree in psychobiology and also a master's in healthcare administration from UCSF, one of our platinum sponsors. So with that, I will leave you in the very capable hands of Ida, and thank you for doing this tonight.
Awesome. Thank you so much, Luis, for that warm welcome. And hi, everyone. I'm Ida Bezabeh. Such a pleasure to be here with all of you tonight and talk about a topic that I'm also very passionate about, justice, equity, diversity, and inclusion. And a huge shout out to Sarah Khan for coming up with that great acronym, the JEDI. For those of you who are familiar with Star Wars, the Jedi are the leaders and the keepers of peace and justice. And so what better, fitting or more fitting term for our conversation today. And so naturally, we expect that all of you will be Jedis by the end of this, but no pressure. As Luis and others have mentioned, when we began planning this panel much earlier in the year, BC, before COVID, who would have known, what these last 6 months would have unfolded into. And I think now more than ever, we know that this conversation is even more timely as we're sort of, fighting two pandemics, COVID-19, as well as systemic racism. And both of those areas really disproportionately impacting people of color and even more significantly, the Black community. So we've got an extremely knowledgeable and amazing group of panelists here today to talk to us about this. And we'll start with a little bit of a general overview about diversity and inclusion, and then we'll talk more specifically about COVID-19 and systemic racism. And as Sarah mentioned, we want to make this an interactive dialogue, so please use the chat box. I think we're all getting a lot more comfortable doing that in this virtual world. So ask lots of questions. We know that there's a lot of experts who are also listening in and have great insights to share with this group. So please share your perspective, and we really want to amplify the collective learning. And before we dive into the panel, I just want to provide a little bit of background information to set the stage for the conversation that we're going to be having today, and what we mean when we say Jedi. We can go to the next slide, please. Awesome. So defining Jedi here, so first, how do we define diversity? Really being the existence of individual and social differences that contribute to identity, inclusion, that intentionally fostering an environment where every individual is valued, respected, and empowered. And then when we think of equity, really being grounded in the principles of fairness and being able to establish policies and practices around that, creating opportunities and ensuring that each individual has the tools and support they need to be successful. And when we think about justice, this sort of spans across all three of these areas in the way that it enables fair treatment and respect for all. Now, why is this important in the healthcare industry? Next slide, please. Perfect. So from the patient care perspective, we currently spend $337 billion in healthcare costs related to race-related health disparities. which is not a small chunk of change. When it comes to the workforce perspective, we know that diverse executive workforce or diverse executive teams outperform their peers by 33% when it comes to profitability. So in both of these aspects, we know that in addition to the enhanced experience and value that diversity inclusion brings to the spaces, there's also a very direct ROI in prioritizing diversity and inclusion. Next slide, please. We can go to the next one as well. So let's look a little bit at what that means in the healthcare industry specifically. So this slide highlights minority representation in the healthcare setting. So the chart at the top is looking specifically at hospitals. So we have a few different populations: our patients, our board members, and leaders and managers. And this data comes from the American Hospital Association, looking at some longitudinal results that they have over the course of 2011 to 2015. So in that very top chart, we see that if we look at the yellow bars, which is the most recent or 2015 data, our patients, minority patients, make up 32% of the patient population. Sorry, my screen froze, but I think we're good now. So minorities make up 32% of the patient population, yet only 14% of board members, 11% of executive leaders, and 19% of management. And then in the chart below, looking specifically at executive leadership positions, we see that across the board, the numbers remain low and pretty flat over that 4-year period, except in the Chief Diversity Officer role. So we see a spike there in 2015, but we also see that a majority of minority leaders in the C-suite are in the Chief Diversity role. And we'll talk a little bit more about that when we get into the panel. Next slide, please. And then switching gears a little bit to talk about current events in COVID-19, we know that minorities are significantly more likely to be impacted and die from COVID-19 compared to white Americans. And specifically, the Black and Indigenous communities, we see that they're 3.8 and 3.2 times more likely to die from COVID. Next slide, please. And then looking a little bit about, as it relates to the conversation around racial justice and what that looks like as it relates to health inequity, we see, there's a long list here and then many other things that aren't listed that really just show how the African American community is more likely to be impacted or die from a variety of the different conditions listed here or diseases. So more likely to die from pregnancy-related complications, 3 times more likely, 44% more likely to die from stroke. And then if we look a little bit down at the bottom, in African American children, we see that infants are 2.5 times more likely to die compared to other peer groups. So I think in all of these examples, the bottom line is really that, there are significant opportunities to close these gaps. And we're really hoping that today's conversation can help us all understand how we might approach this and continue to build upon the progress and momentum of this moment. And so with that, we're going to dive right into the conversation, and I will introduce our amazing speakers. Starting with our first panelist on the left, Efton Hall, Jr. So Efton is a Senior Vice President for Healthcare, Life Sciences, and Public Sector Practices at Berkeley Search Executive. As a multi-practice leader, Efton manages client engagements as well as middle and senior level executive searches in hospitals, health systems, life science companies, and public sector organizations. Efton also spent several years in the industry as a healthcare executive in 2 prominent Bay Area healthcare systems. After achieving his goal of updating his skills and knowledge in the field, he returned to his firm in 2008. Efton's experience in hospital, health systems, and the public sector distinguishes him amongst search consultants with similar specialties. He earned his BA from Stanford University and his MPH from the University of California, Berkeley in hospital administration. Next, I'd like to introduce Anna Dapelo-Garcia. Anna is an inclusion, diversity, and health equity leader at Stanford Healthcare. She is founder and president of Lean In Latinas and serves as the current vice chair and board member for the University of San Francisco Master of Public Administration program. She's also vice chair and board member for the Hispanic Foundation of Silicon Valley. In 2018, she was appointed by the Santa Clara County Board of Supervisors to the Women's Equality 2020 Leadership Council. Among her many awards are the following: Latino Leadership Award by the Silicon Valley Business Journal, Top Latino Leaders Award by the National Diversity Council, Women of the Year by Women Healthcare Executives, woot woot, and Silicon Valley Business Journal Women of Influence. Anna obtained her Master of Public Administration from the University of San Francisco and Bachelor's of Art in Management from St. Mary's College. And then moving on to our next two panelists, we have Dr. Carla Wicks, who is the Regional Director for Culturally Responsive Care and Inclusion at the Permanente Medical Group, Kaiser Permanente. In this role, she integrates culturally responsive care and inclusion into daily operations and interactions with patients, physicians, employees, and the broader community served in the Northern California region. Dr. Wicks is a graduate of Northwestern University and the Howard University College of Medicine. She completed her residency training in obstetrics and gynecology at UCSF, where she was twice awarded the Outstanding Medical Student Teaching Award. In addition to all of this, Dr. Wicks is also involved in community and academic pipeline programs, providing mentoring opportunities to students who are underrepresented in medicine. And our final panelist that I'd like to introduce is Kelly Flannery. Kelly is the Chief Planning Officer for the Department of Veteran Affairs Sierra Pacific Network, serving veterans in Northern California, Nevada, and the Pacific Islands. In this role, Kelly spearheads the development, annual review, and management of the strategic operational plan for this integrated network, encompassing 7 healthcare markets, 10 VA medical centers, 57 VA clinics. In 2019, Kelly was appointed to the VA Regents Advisory Council and serves on the Strategic Goals Task Force and is a liaison to the Diversity and Inclusion Subcommittee. He earned his Master of Healthcare Administration degree from Walden University and Bachelor's of Art in Theology and Religious Studies from the University of San Francisco. Kelly is a board-certified fellow for the American College of Healthcare Executives, a 2019 Thomas C. Dolan Executive Diversity Program Scholar, and a member of ACHE's LGBTQ Forum. He is also a member of CAHL's Diversity and Inclusion Committee. So, as you can tell, we have quite an amazing lineup of panelists, and it's really clear that this topic is something that they're passionate about, not just in their day jobs, but in the things that they do outside of work and where they spend their time and energy and passion. So as we move into getting started into this conversation, would love to hear from each of you why this topic is important to you.
This is Efton. If I may, I'll go ahead and start. It's important to me because my life has been devoted and invested in equity as it relates to healthcare within the communities that I've lived. I grew up in Oakland. I've never lived more than 45 miles from Oakland, so I'm clearly a Bay Area product. And I have some examples I'll share as we speak regarding the manner in which I have acted out, just how important this topic is.
Hi, this is Carla. I'll go next. I believe that passion fuels your purpose. And me personally, I've always had a passion for diversity, equity, and inclusion. I'm the descendant of many generations from the Great Migration, moving from the South to the North, originally from Chicago. And growing up, I saw you know, opportunities and the lack thereof for family, for myself, for friends. And, you know, for me, all my life, I've thought about how can I make a difference? And that fire, that passion within me, just placed me in the universe called, placed me in this role. And, you know, I'll continue to do the work that I need to do to create equity for all. So thank you.
You're on mute,
Anna, we can't hear you. Oh, yeah.
Anna, do you want to go ahead? Okay. All right. Good evening, everybody. I'm Kelly Flannery. I'm happy to be here with you all. You know, for me, I've become passionate about this over time. As a gay male, I knew I was gay when I was, you know, a child and growing up, and basically, you know, for the earlier part of my life, I was living, you know, a double life, and not sharing myself and being honest with others around me, including at work. So, you know, I think over time, I've grown to love myself and be comfortable with who I am. And so I would definitely say that over time, I have found my Jedi voice. So I don't think, and I envy the youth today, you know, men and women who are in their early 20s and they're out, or actually in high school, and they're openly out in high school. So definitely I don't want the younger generations, the upcoming generations to go what I went through. So that's why I'm passionate about this. Thank you.
I think people can hear me now.
Yeah.
This is Anna. Yes, very good. Thank you so much. Yeah, there are several dynamics here that make this topic really important to me. First, in being a Latina person of color, part of a community that we know has been hit very hard by this pandemic, you know, growing up in a crime and poverty-ridden neighborhood, experiencing firsthand various issues due to this lack of health insurance for many people, access to healthy food, preventative care. With these issues even more magnified with COVID-19, and it feels like a nightmare every day, resulting in disproportionate deaths among many people, particularly in our Hispanic and Black communities. I grew up in the very zip codes in San Jose where we have the highest rates of COVID-19 in Santa Clara, which is, as of this morning, and looking at Santa Clara County's COVID dashboard, 48% of infections are among Latinos. And although the population, it comprises just 25%. So definitely very personal to me. Second, in my role at Stanford Healthcare and as part of the work that we're doing around inclusion, diversity, and health equity, and the investments that we're making around health equity, around racism, I'm just really glad to be part of this discussion. Thank you very much.
Great. Thanks, everyone. So as we get into this conversation, to really level set and give the audience a baseline understanding, how does your organization define and assess diversity within your community?
Mine will be very easy. My organization is small, Berkeley Search Consultants, and we start with a very clear statement that we actually wear on our website. It's our faces. We are diverse as a company. We also have adopted a posture where we are including a diversity commitment in every executive summary, every proposal, every response to an RFP that we send out. And we are continuing to escalate and advance our stance as it relates to our company through the clients that we will actually associate ourselves with in terms of agreeing to do search work. Those companies that we agree to do search work at this point in our existence need to also have a clear statement for diversity in terms of their organization, their recruitment philosophy, and their intent in terms of establishing through their search processes further continuation into diversifying their workforce.
So this is Anna. You know, I really love this question because in the many years that I've been at Stanford Healthcare, in many ways, our diversity really defines us as well. We're a very diverse organization, which, you know, I'm very proud to be part of. But we do know that, you know, some of the opportunities that we see is really, are we seeing that diversity at every level of the organization? I mentioned the Inclusion, Diversity, and Health Equity Department. That's a fairly new department for us. And, you know, we're sort of looking at what does diversity mean to us? What does diversity mean to our employees? In what strategies have we, you know, need to look at to really amplify our diverse workforce and our hiring practices? You know, how can we show our diversity to the public? And, you know, it just seems that in every turn, what can that mean to us? How can that resonate also in the community? And how can that resonate, you know, among our patient populations? So again, very new to this work, but a very diverse organization.
Great, thanks, Anna. And you know, a little bit of what we've talked about, you know, understanding that a lot of times diversity and inclusion is really top down and really starts with the leaders. Efton, can you talk a little bit about what you're seeing in terms of the hiring and recruiting practices with the organizations that you're working with?
Thank you. Yes, I'd be happy to. And now that I see we're probably a critical mass in terms of members on the event here, I want to once again just say thank you to you all for your participation. It's a pleasure to be here speaking with you and having this opportunity to say it out loud. What we see in terms of organizations is a pretty good mix of starting points, you know, where they are in their process. Let me give an example of Marin County. We recruited the Director of Health and Human Services for the County of Marin. And I have their, what do you call it, their 5-year business plan in front of me right now. I just want to give you a couple of citations from that business plan. It's a public document, so I'm sure they wouldn't mind me sharing this with you. They have focus areas and strategy in terms of ensuring diversity at all levels of the organization. So when we were interviewed for the assignment, they laid this out for us and said, this is what we are about. Tell us what your firm is about, and let's see if it would be a good partnership. And the strategies include creating partnerships with the local colleges in order to create career tracks that in turn turn into pipeline to their organization. It also talks about developing and delivering cultural competency training within their workforce. As it related to our work, they had specific metrics that they, first of all, were taking a serious look and revising their qualifications criteria so as to eliminate unnecessary barriers to employment. And they also had metrics that related to the nature of the candidate pool that would be presented for any leadership position, and in particular the position that we were recruiting for. And that candidate pool must have a certain metric in terms of a diverse membership within the candidate pool. So we were duty bound to produce a diverse candidate pool, and I think that's where it starts. No, actually it starts at where are these people coming from? So going back to the schools, going back to the community, going back to what they were laying out as the criteria by which they would evaluate and then process through a recruitment process individuals was key and a good learning in terms of a model that seemed to have some efficacy to it. The outcome was a diverse candidate pool for that position, and coincidentally, the outcome, the champion, when you have a diverse candidate pool, you have an opportunity to actually add the richness of diversity into your organization, which in fact was the outcome in that particular search. The thing that I've done recently is I've wondered, why am I being invited to this panel? And I think I embody a dimension that is both experience as well as age. And diversity isn't just about race or gender. It's also, who has seen a few wars in their time. I've seen a few wars. I started the first and only Black-owned and operated hospital in Northern California's history in 1974. Have I been in the game for a while? Yes. Am I conscious and aware that there's some disproportionate and imbalances in terms of who receives care and when and how and with what level of integrity? Yes. Have I attempted in any way that I could to influence through my actions, through my conduct? Yes. So what we're seeing today is not only the Marin County example. Another quick example is a interview that recently took place where, again, we were a search firm competing for an assignment in the Michigan market to recruit for a senior vice president, chief human resource officer. And in that particular interview, there were two questions that the president and CEO of the system and the incumbent chief human resource officer asked. One was, what is your company's approach to ensuring that there will be a diverse candidate pool? And the other was about our reach in terms of our ability to source candidates nationally. I was very impressed that those were the questions that ended up being sort of the final determinant. And finally,
and it sounds like,
go ahead.
Sorry. I was going to say, it sounds like what I'm hearing is that very specific intentionality, starting with having a strategic focus on this from the organizational level, and then also how does that, how do they operationalize that into metrics and the very specific criteria that they're using to make these assessments?
Very well put. Thank you for synthesizing that. And if I were to just continue that stream, what are the stated values, the mission? What's the policy that evolves from that? What's the training that is then made available to all of the stakeholders within the organization? And how do they measure whether they're being successful with whatever those goals are? Is there the dashboard? Is there the analysis? Is there the reporting and the gap analysis? And then repeat and rinse and continue to improve based on observations where there are gaps.
Great. Thank you so much for that, Efton. And I think, thinking of that, shifting gears a little bit, so thinking about that on the provider side of things as well, we know that a part of delivering culturally responsive care is about building a diverse network of providers that really represent the community that they're serving. Dr. Wicks, can you talk a little bit about how your organization is addressing this and more broadly thinking about culturally responsive care?
Absolutely. So thank you again. So I'm the Director of Culturally Responsive Care in the Permanente Medical Group. So our organization in Kaiser Permanente is really divided into 3 entities: the physicians, clinicians in the medical group, the health plan, and the hospital. So overall, as an organization, we believe in equity and inclusion for all. And part of that is that we weave it into the fabric of everything we do. So hiring and recruiting and retaining a diverse group of physicians, because I'm representing the physicians group, is part of that fabric as well. And it's so important that we commit to doing it for our patients and being able to provide them options of a diverse group of providers. It's important that we do it for our people, so those we work with, to be able to understand each other's differences. And it's really extremely important as we strive to improve the communities that we serve, that it matches the communities that we serve. So we have a robust team that has been assimilated to really dive deep into the care delivery side and the culturally responsive care and inclusion side of EID or JEDI, right? And some of our strategies are fairly new. Some we are reinvigorating, but overall, we're tapping into networks of pipeline programs. We're enhancing our marketing and branding strategy as far as recruitment. We actually have a group of physician ambassadors who help us brainstorm ideas, and then they actually go into their own networks and go back to their medical centers and go back to their medical schools and residency programs to really spread the word about how amazing it is to work for the Permanente Medical Group. So we have a host of activities around diversifying our physician population. And it's not to say that it's easy, but it's a journey. As far as our retention and hiring, that's another part of recruitment. Once you recruit physicians, you have to hire them. Once you hire them, you have to retain them. So we're looking at ways to build structures to support our physicians, newly hired physicians, in particular, our underrepresented minority physicians who are often sometimes the one and only, or may not necessarily be in the most supportive situations at home in their communities. So we're looking at ways to support. And also, you know, culture is such a big piece. The culture of the organization is really an important piece around retention. And so we are enhancing a number of our education and development initiatives around bias training and speaker series and a number of other offerings to really ensure that everyone has those foundational elements so that our culture and our philosophy are sustained. So that's just a little snippet of what we're doing for our physicians, and thank you for asking.
Great. Thanks, Dr. Wicks. And I think you bring up a really good point there. There's sort of the recruiting and getting people in the door piece, and then there's the inclusion piece, and how do we make sure that people feel welcomed, have that sense of belonging so that they stay, right, and we retain them. Mm-hmm. And as we think about that, Kelly, I would love to hear from you, both from your experience at the VA and with the ACHE LGBTQ Forum. What strategies have you seen work well in terms of fostering inclusion?
Sure, thank you, everybody. And I'm glad that I got back into the meeting. We lost all the power in the House for a few minutes. So I literally had to reboot my computer and go through the entire process to get back online. So I'm glad I'm back. Thank you for the question, Ida. You know, as far as strategies for fostering inclusion, I think that, you know, from the LGBTQ and VA perspective, you know, easy wins, I think, are really tangible, and they don't come with a huge price tag on them. You know, it's kind of like the low-hanging fruit, easy wins. And by that, I mean, you know, be visible and be vocal in your organization. And that's from leadership all the way down to the frontline staff. Nothing is going to get better with silence. And, you know, as far as kind of my take on things, I think pretty much everyone is aware that, you know, the rainbow or rainbow flag or ribbon has become a symbol of the LGBTQ community. And so that's a real easy win as far as, you know, if you have a rainbow flag lapel pin, you can have that affixed to your clothing, or you can put it on your ID badge holder or a lanyard. Speaking of which, show you some swag here. You know, the VA put this out. We created these this past Pride, and so it says VA serves all who serve. So, you know, this type of visual indicator, I think, is really an easy win, low-hanging fruit. Also, you know, posting your non-discrimination statement throughout the facility, and LGBTQ affirming posters are another good visual. Also, community commitment, I think, is important as well. You know, going beyond the walls of the institution and connecting with the community. Most people are probably well aware that, you know, every June it's Pride Month. And so participating in Pride celebrations. Many large cities have Pride parades, specifically here in the Bay Area, you know, San Francisco and whatnot. And with the Pride parades, there's also usually like a rally and a celebration area at the end of the parade route. So I've seen several Pride events or Pride celebrations that I've gone to in the area that healthcare systems, they have staff that march in the parade. And they also set up booths at these celebration areas that are part of Pride. I don't think Sacramento has a parade, but I know that they do have celebrations, I think shutting down the Capitol Mall. So, so yeah, I mean, I think those are really good things to do to show the community, show staff, you know, that there is that commitment there to fostering inclusion. One other thing that I'll just throw out there as well as a really impactful and strong statement, I believe, is as an organization's participation in the Human Rights Campaign's Healthcare Equality Index. That's really strong because it's voluntary. There is no federal mandate that all healthcare organizations have to participate in the HIE. It really is a healthcare organization's choice to do that. You know, kind of be vulnerable, but also show what you're doing. And as a part of that, you know, you get scored. The top score is 100. And HRC usually will celebrate organizations that are top performers, that are, you know, at 100 or 90 to 100, maybe 80 to 100. I'm not quite sure off the top of my head, but they do recognize the top performers. And in fact, in our network, my network, this VA network that I'm in, this VA Sierra Pacific network, we have 2 facilities that are top performers on the HEI. Our healthcare system based in San Francisco, and our healthcare system based in Reno, Nevada, are top performers. And our healthcare system based in Palo Alto and Pacific Islands and Las Vegas, they are 2019 healthcare equality leaders. So 5 of our 7 healthcare systems are participating in that, and that's really great. I think that is a really strong statement, very impactful. And last but not least, I'll just throw out that I think the VA can serve as a model and a reference for others. we're obviously a very large organization, very large healthcare organization, and we have a VA Office of Diversity Inclusion. We have special emphasis programs, Federal Women's Program, Hispanic Employment Program, African American Program, Asian American, Pacific Islander Program, American Indian, Alaska Native Program, and last but not least, the LGBTQ Special Emphasis Program. So I think that although, comparatively we are so huge compared to most health organizations, I think that, there's always something that we can share with the private sector as far as that goes. So yeah, I'll go ahead and stop there. Thank you.
Great, thanks, Kelly. So what I'm hearing you say, really a few of the key things that you mentioned was being visible and vocal. We can't expect, as leaders, we can't expect our teams and our staff to understand, where we stand on something if we're not willing to have those conversations with people, breaking the silence, and really more of the show don't tell and getting out in the community and showing support for that. Awesome.
Yes, yes.
So I guess as we think about, in addition to diversity and inclusion, also just thinking about the equity piece and how are we ensuring that folks have equal access to opportunities and resources. And so Anna, as the founder of Lean In Latinas and member of the Women's Equality Leadership Council, I know that you've done a lot of advocacy work around equal pay, and would love to hear a little bit about that work and what strategies you've seen work well in terms of advocating for equal pay and just equity at large.
Yeah, thanks, Ida. If anything gets me up in the morning every day, it's really what can I do as part of Lean In Latinas, founder and president of Lean In Latinas, which is actually part of the Lean In organization. So I have been on this journey for the last 5 to 6 years. I certainly would want to see the numbers improving. There's some improvements, but I think it's important to start with the facts around equal pay. So, from the Institute for Women's Policy Research, all women on average make about 18% less than white males. Black females, 38% on average less. And for Latina women, there is a 45% wage gap. And when I share that information, it still surprises me how many people are surprised by that. Fortunately, we are seeing some incremental improvements, but it's very small. So for example, 2 percentage points that we've improved since I started this journey for Latinas. There was a time that I was out on speaking circuits saying 47%, we're at 45%. And for all women, 20%, now at 18%. But interestingly enough, for Black females, it stayed pretty flat at 38%. So clearly we're nowhere where we need to be to make some material impact and hopefully eliminate the pay discrepancies. One of the catalysts in really understanding what some of the strategies are, certainly what's fueling this, on an annual basis, McKinsey and the Lean In organization collaborate on the annual Women in the Workplace report. So all of the information that I'm sharing with everybody on this call, you can get it directly from the Lean In website. And that annual report is a little bit of my Bible, of what I really look at. It's the largest study of the state of women in corporate America. It's a collection of information of about 329 organizations surveying about 68,000 employees to better understand day-to-day work experience. And so I'm going to highlight a few things from the 2019. And what came out loud and clear is that women are underrepresented at every level in corporate America. And one of the fundamental theories that came out of the research is what's called the broken rung, which is one of the biggest obstacles for women that we face, I should say, to help close the wage gap. So let me talk a little bit about what that means. The broken rung is how do we get to gender parity? And it's really looking at and highlighting women are less likely to be hired and promoted to manager. So a little bit of stats around that. For every 100 men promoted and hired to manager, only 72 women are promoted and hired. men hold 62% of manager level positions, while women only hold 38%. The number of women decreases at every subsequent level to the C-suite position. So based on this research and in the study and sort of running some analytics, if women are promoted and hired to first level managers at the same rates as men, we would add 1 million more women to management in corporate America. So what's very interesting is when people talk to me, they said, you know, is it really around women not negotiating for pay? And at some level, there is some opportunity with that. But what's important to say is that the strategies to reach equal pay are not solely on the shoulders of women. It's not around pay negotiation skills. It's really addressing the structural issues that have supported men more than women in the workplace. And it's really time to address those issues. So it's really getting to really what is the root cause around the pay gap between men and women.
Thanks for sharing that, Anna. Sorry, I have an Anna.
you can call me Anna.
And it looks like we have a few questions in the chat around both that topic around equity and equal pay and some other things. Sarah, did you want to run through some of those questions?
Sure, and just in the interest of time, I will consolidate a few questions that are similar. Audience members, please do submit your questions via chat, either publicly to everybody or to me or Navpreet Atwal privately. That's completely fine. The first question is, and all of these questions will be anonymized just to protect the submitter's identity. Justice, equity, diversity, and inclusion require people to be mindful and to look through multiple lenses. There are, naturally, education is key, awareness is essential. How do we move the conversation toward action and systemic policy changes to see the changes we sorely need versus just being sympathetic to the issue?
So this is Anna. I'll talk a little bit about that. Yeah, so, you know, it's very interesting. People want to take action right now on you know, whether it's the Black Lives Matter, but we recognized at Stanford that listening is an action. So, you know, part of sort of the lens that we're looking through, you know, we are conducting numerous listening sessions this month with staff, our Black employees. We don't want to make assumptions. We don't want to try to jump to strategies. We recognize and honor that listening is an action. So that's one way that we're sort of approaching, what does it really mean to have an equitable organization? What does that mean through the lens of whatever position that you're in, or you know, how you represent yourself when you come to work, who you are. So, you know, we've been very deliberate in saying to ourselves, listening is an action, and we're really going to do that to really understand what some of the problems are. What does that really mean to us as an organization? And how do we show who we are, obviously, to our community?
Great, thank you. Would anybody else like to chime in? I have 2 other questions.
This is Carla Wicks. I'll just echo that. I agree. We're doing similar action planning now. And step 1 really has been about listening. And we're still in that phase. And we'll continue to listen without a definitive end date. Our strategy around listening is to really also activate those who may or may not have been aware of a number of these issues, to start these conversations and dialogue, because I think that it's everyone's work, not just the work of myself and my team or the leaders, but from the bottom up, top down. And so this has been an really impressive engagement strategy, as well as an action item. So I just wanted to emphasize how how powerful it's been.
Mhm.
We have an interesting question. It actually came from 3 different people, and it's different angles of the same question, so I'm clustering it all together. This is from the applicant's perspective. How does someone who is better qualified than a non-Hispanic Caucasian counterpart at work demonstrate potential and ability to take on leadership role when perhaps their leader has passed them over in favor of a less qualified Caucasian candidate in the past? That's one question, is from the employee's perspective. From the employer's perspective, how does one go about building diversity and creating greater inclusion on your team? And from the employer's company's perspective, the question is, are there incentive programs, state or federal, where the organization can build and basically incentivize greater diversity within their companies?
I think timing, as Anna has mentioned, is everything, and now is the time. The time for individuals from the employee's perspective to really stand up and speak up regarding their interests, their intention to explore the career opportunities within their organization, to make sure that they are clear. A concept that I learned too late in life was internal to your organization, there is a mentor opportunity and perhaps external, and there's also sponsor opportunities. Make sure that you're aligning with the mentors and the sponsors who can guide, coach, make a difference, open doors. And at the end of the day, everyone needs to feel appreciated and valued. And if in your organization, after all that you do and all that you say, you feel that that organization, whatever the structure is, whomever the reporting relationship is not acknowledging your value, is not embracing your interests in continuing to train up, continuing to grow, then ask yourself the tough question: is there a better organization for me that may in fact allow me to flourish and thrive and be my best self?
Sarah, I think the first question that you summarized was related to one candidate being selected over another, and is there any recourse, basically. In the VA, I have to be honest, I don't know if this is like codified in writing, but I can tell you though that the common practice is, especially with positions that are increasing in responsibility and moving up in the organization, you know, supervisory, like frontline supervisor, and then a manager, and just, you know, those higher levels of responsibility, that we try to be as supportive to the candidates who were not selected, and giving them feedback. You know, the VA has, I think, one of the reasons that I'm here talking to all of you is because the VA has invested a lot of time in upward mobility programs, so that, you know, people don't come in kind of more like an entry level position and they're just stuck there. You know, such a huge organization that we want to grow from within. And so it's pretty common practice that when we get into higher level positions that there is feedback, because usually the person, you know, that, well, everybody that applies for a higher level position, basically a promotion, you know, they want to start moving up. They don't want to be stuck where they are. So I think that's one thing that I can pat us in the VA on the back about, is that we actually do that. We try to give some feedback to the candidates not selected. We point out areas that they can work on, especially as far as interview skills. That's really a big one. I've been on interview panels and looked at ranked resumes, and people that I thought were really, really good on paper basically just kind of fell flat on an interview. So I do have to say that VA does value that, growing our own and helping people as best we can move up the organization.
Yeah, this is Anna. The only thing I'm sort of thinking through right now is, you know, I would say some departments are better than others. Maybe some organizations are better than others around, you know, is it a clear path? You know, does an employee even understand what the process or the path is to move up? And that's not always clear. And I think it just leads to situations where folks don't understand why they're passed up. You know, you don't want to make it so mechanical, you know, the process, but you do want to make it clear, you know, how do you get promoted in this organization? How can you get mentoring and sponsorship? I climbed the ladder, so to speak, at Stanford. Some of it just me trying to figure it out. The other part of it is, you know, having structure around what that really looked like. So, you know, that would be one question for me is it clear on how to move up or not?
Thank you so
Yeah.
much.
I basically did the same thing, Anna. I've been in the VA 21 years, and I started as an anesthesia technician in the OR. So I basically, nobody handed me opportunities. I basically sought them out on my own because, you know, 20 years ago, it really wasn't as clear. So.
Yeah. And it sounds like there might still be opportunity there, you know, from the employer's perspective, really taking the onus of clearly defining what that path is and making the path to understanding that a lot more equitable. Awesome. Great. Well, thank you all so much. We're going to move along to shift gears a little bit and talk about COVID-19. And we'll get back to more of your questions. So please keep chatting away. I see the chat box like blowing up, which is awesome. And so as we shared earlier in the slides, definitely seeing how COVID-19 has disproportionately affected people of color. And we know that there are, you know, a variety of systemic inequities and social determinants of health that make communities of color more susceptible. So Dr. Wicks, can you talk a little bit about why COVID-19 has disproportionately impacted people of color and some of the larger structural issues that might be at play?
Absolutely. So I'd like to think of this analogy. We had a bandage over a gunshot wound, and COVID-19 yanked it away. So COVID unveiled the inequities that already existed in this country, as you said. And as a result, they disproportionately affected mostly people of color and still are to this day. So if we think about this, it's multifactorial. It's not just one thing. Let's think about the context of the social determinants of health. They're in parallel with what makes us healthy as human beings, whether it be food, socioeconomics, education, housing, access to care. That's all a part of how healthy we are. And imagine any of those being vulnerable or non-existent. So then you layer on these structural issues. And one example is the concept of structural and institutional racism. And it's different than individual racism, which is on an individual basis. Institutional racism really is about the policies, the practices, procedures that work better for those who are white than for those people of color. And this may be unintentionally or inadvertently. So if we think about that, which is institutional racism, Then we consider structural racism. And structural racism really brings in the element of history and our current reality of the institutions, combining them to create a system that negatively impacts communities of color. And that's what we see. Communities of color being impacted by this, in addition to the social determinants of health, taking on more disease burden and chronic conditions, making them less healthy, more vulnerable to COVID. There's another layer of implicit bias and other microaggressions, et cetera, that is a part of this. And if we think about the way that bias and structural racism play out, they're all based upon these assumptions, right? In addition to the policies and procedures. And then we create these inequities in healthcare, and it's a vicious cycle. So this is our problem. Some of this is decades, other is centuries of an issue. And COVID really just exposed what we already knew.
Thank you for that, Dr. Wicks. Yeah, no, and I think the example of the bandage on the gunshot wound totally resonated with me. And so that helps us to just kind of understand what are sort of the larger factors at play as we're thinking about this. And then in specifically in the COVID-19 space, what gaps has this highlighted in our healthcare system, and how are your organizations responding to this?
Should I take that one first?
Go for it.
Okay. So, you know, again, because it's multifactorial, I think how we respond to it is also quite complicated. We have our active COVID response team and mechanisms and workflows. And if we think about digging deeper and have a lens of culturally responsive care and equitable care, what we've done is that at certain checkpoints, we began to influence. Okay, here's an example. You set up drive-through COVID testing at a center in a particular area in the Bay. And if you think about the socioeconomics of certain patient populations, or just in general, human beings, they may not have a car to drive through. So having that lens on how we develop our workflows in response to COVID is really important. When we think about language being one of the core factors of communication to our patient population as well as our communities, it's really important that we enhanced our patient education and resources to really outreach to patients and say, okay, here's COVID-19, here's what we need to know, here's what you need to know to keep you and your family safe, here's how to get tested, here's how to book appointments, all in your language. Like, that's a really important piece of this as well. And then when we, as in response to this dual pandemic, where we have COVID-19 as well as a movement around racial equity, we developed a really robust response. And as I said before, part of it was listening. Some of it included our highest leaders in our organization speaking out against structural racism. I mean, it was monumental. And not just words or letters and speaking out, but really outlining, here are the core focus areas that we will commit to as an organization within Kaiser Permanente: workforce inclusion, health equity, addressing systemic inequalities, addressing systemic racism and trauma. That was their call to action for us as an organization. So that's just a little bit around how we're responding to COVID-19 and this release of the hemorrhage from the gunshot wound.
Hi, this is Anna. I can speak a little bit about how we're responding. We do have a newly developed Stanford Medicine Health Equity Committee, and it has representation from not only the School of Medicine, but Stanford Healthcare and Packard Children's Hospital. We know that one of the key paths of work here is around COVID-19. One of the areas of focus is really looking at outreach, and Carla said that. I think that's absolutely important. Outreach and engagement, and really looking at how can we further support care, preventative care. That is not something that preventative care wasn't really a focus, at least in the neighborhood that I grew up with, and so when I'm sort of reading these stories about what is fueling, whether it's deaths or severe cases of COVID, really predicated on, diabetes, et cetera, we're really going to have to, as a society, get our arms around that. COVID, unfortunately, just magnified these issues, and it was said earlier, that have existed. I think another good strategy is really not doing things to patients, for patients in the community. It's really doing with the patients and families. So in really looking at this work is, how can we include the patient's voice at the table? How do we get their perspective as well, to add their voices? So I think that's one path of work that we're doing around this issue.
Thanks for sharing that, both Anna and Dr. Wicks. And it sounds like in both of these situations, I mean, as we're talking about both the workforce, but actually how we're also designing for patients, really taking them along on the journey with us, similar to the listening session that you had mentioned that you're doing with staff, and helping, having them help us understand, where the needs are and how we should be solving for that. Awesome. And so as we, amidst this global health crisis, the transgender community has also been facing another challenge. In June, the Department of Health and Human Services finalized a rule that removes protection for gender equity and sexual orientation, which could result in the denial of care for transgender people in the midst of a pandemic. And so as a healthcare community, how is the healthcare community responding to this? And how can we ensure access to care for our transgender community?
That's a big question, Ida.
No pressure, Kelly.
I know, no pressure, my gosh. Well, good question. I think that, on a macro level, there's been pushback, condemnation of the HHS rule from the American Medical Association, American Hospital Association, even Catholic Health Association of the United States. Politically as well in Congress, many of the caucuses came together for a joint statement. The LGBTQ+ caucus, Asian Pacific American caucus, Hispanic caucus, Black caucus, pro-choice caucus, they all came together and, these, like I said, on a macro level, expressing support for the LGBTQ community, especially trans, and just, condemning this rule that came out of HHS last month. And locally too, basically the same thing. Stanford Medicine, Kaiser Permanente, UC Davis Health. I mean, they're not surprisingly a lot of the big healthcare organizations here in California are saying the same thing. I have not heard of any healthcare organization that's basically dropping the LGBTQ community as far as healthcare goes. So that's really good. I think ensuring access for the transgender and also the overall LGBTQ community. I think acknowledging that cohort as a COVID at-risk community is important. The HRC put out a report about a month or two ago, basically addressing this whole topic, and really some of the the takeaways were that they are an at-risk community. Some of those factors were because of the jobs they have. A lot of the communities in healthcare, service industries, teaching. There's also some fair amount of poverty that's still in the community. And lack of paid leave, but for the poverty, LGBTQ youth, especially trans individuals, still they suffer from homelessness and being disowned maybe from their families, and so that's definitely a factor that comes into play here. And lastly, health disparities between my community and the non-LGBTQ community. There's still a fair lot of cigarette smoking that goes on, diabetes, and alcoholism. So, you put all these things together. It's just that the LGBTQ community is an at-risk community. I think, general considerations for healthcare organizations, I think it's back to the basics. Affirm the organization's mission, vision, and value statements, and renew the commitment to equality and health equity. Basically, embrace your integrity. Despite what Rule HHS puts out, kind of get back to your roots and affirm that you're serving everybody in your community. Of course, in California, we're, a little bit of a distinct state because we have a law in California about, prohibiting discrimination based on gender, as far as healthcare goes. So that's an additional factor for, California. And lastly, I'll come back to it, VA can serve as a model and a reference for other organizations. We have directives, Veterans Health Administration directives. The first that came out was, regarding the provision of health care for veterans who identify as lesbian, gay, or bisexual. And then a follow-up directive came out specifically for the transgender and intersex veteran cohort. So, we have directives that basically, directive is just, there's a purpose, a background, definitions, the policy, delineated responsibilities and references. So we're basically, VA has codified into our organization that, we reach out to these communities, we treat them. And there's nothing in, a Title 38 benefits package for veterans that, distinguishes between, white, straight male veterans versus a transgendered veteran. That doesn't happen. We treat everybody. So, again, we're staying true to our mission, and I think that, I suspect that most of the people that are on this call are probably within, California and the CAHL catchment area, so that shouldn't be any surprise. But yeah, I'll go ahead and stop there because I know we're short on time.
Thanks so much for that, Kelly. And switching gears just a little bit, we touched on it a little bit throughout the discussion, but wanting to talk a little bit more about racial justice and how some of your organizations might be responding specifically to that in our current climate. And so just wanted to get a sense from all of you of either, we talked a little bit about, or Dr. Wicks talked about structural and institutional factors and how that plays into things. Would love to understand any structural changes or any initiatives that your organizations have that are sort of addressing this current moment around and the conversation around racial justice, or anything that you would like to see organizations more broadly do.
Yeah, so this is Anna. So I did mention the listening sessions, and this has been hard, to just see in our country. It's hard for me as a person of color. It's hard to see, friends and colleagues of mine, Black friends and colleagues of mine, in real pain and real anguish. And what I'm pleased about, at least at this time, is the fact that we are dealing with this topic head on at Stanford Healthcare, and I am a long-term employee. We recently had a virtual leadership summit in direct response. In fact, this quarterly leadership summit is planned many months ahead. But because this topic is so important, the leadership pretty much scratched what we were going to do and said, you know what, we need to talk about this issue. We need to talk about what we're going to do around anti-racism. And when our president and CEO sort of got up there to talk, that was a very critical point. Not only did he acknowledge that, there's obviously racism in our country, racism in our community, but when he said, we need to deal with racism in our own organization, that was the turning point, really, because I felt that if he wouldn't have said that it would have been a real problem for us as an organization. And so, just him saying that really, because this is a hard topic for people, people, managers, leaders are coming to the inclusion diversity department saying, I don't know how to help, especially if they're not Black. I don't know how to have this conversation. I don't know what to do. And in one of the listening sessions that we had the other night, this one employee said to me, the very fact that my supervisor bought me flowers or just said, I don't know what to say. But the very fact that we're now saying we don't know what to say is progress. Like, how do we have these conversations? So we actually are looking to conclude our listening sessions by next week. Our plan is to then work. We do have employee resource groups to work with our Black employee resource group leaders, sit with our executive team, with recommendations. They really want to know what employees are saying, and it's not all great stuff, right? But it is what needs to be said. It is that person's experience. It is the life through their lens that we need to pay attention to and respect if we're going to make any real change. And let's not pretend it's going to be one strategy or one initiative. This problem has been living with us for many, many years, unfortunately. So I feel that, that we're on the right path, but I don't think anybody has all the answers. I don't know anybody who has all the answers at this point, but the very fact that we're having a conversation about it, listening, I think are really good steps forward.
Thanks for sharing that, Anna. Efton, any thoughts that you wanted to share on this? I know earlier in the discussion that you mentioned that there might be some things that you wanted to chat about. Oh, you're on mute, I think.
Yeah.
There we go. Sorry. I'll attempt to be brief. There are 13.4% of the American population are Black. That's 40 million people. Over 2 million individuals over 25 have advanced degrees. And to the leaders and future leaders on the call tonight, there is a growing problem. Yes, racism has had its mask removed. Someone stomped on it on the floor, and now it's the other pandemic, and it's probably not going to come back on. But we have this dynamic tension. There is an outmigration of Blacks from the C-suite, from organizations, because of issues that have been discussed throughout here. And with that outmigration, where are these individuals, very qualified, very capable, well-educated, going to other opportunities where they can be their own boss, where they can control their own destiny. So as we are getting our policies together, our diversity recruitment practices together, it's equally important to understand that embracing and taking care of the individuals that are in the organizations today is critical. Creating the mentorship, the sponsorship, the growth, the paths forward, the conversations internally. And as a result of that, we may be able to arrest the flow out. And if we can arrest the flow out, we can have some time to do the training, the deep dives, the developments, and the maturation of the cure to this particular pandemic. It will take time, obviously. The outgoing and retiring chair of the National Black MBA Association, who's had 14,000 members, half are in school, half are out, has spoken very definitively on this topic. And it's returning, this out-migration is returning to a period that was prior to the Civil Rights Movement, where Blacks had to do their own thing, be their own boss in order to make a living in many instances. Unfortunately, we see some slippage where that's going back in that direction. So if we simply understand that this issue is not going away, set our policies, and let me leave you with this one thought. Sustaining the policies and practices that are coming into our organizations today, the diversity officers who are the compliance officers of this program, this effort, these initiatives, they have to be sustained and given the authority and the opportunities to actually make the difference that they are in place in order to change the tide that we're seeing. I know we're out of time, so I'm going to stop there.
Thank you so much, Efton, for closing us out with that. And as we wrap up the panel, just want to, again, thank all of our panelists for sharing their insights with us and really the passion around this work. This is definitely a conversation that we could have continued on for hours, and I know personally I was getting really comfortable. But in the interest of everyone's time, we're going to be wrapping up, and I think the biggest thing, you know, I think now more than ever, we all have a responsibility as healthcare leaders to really think through how we want to redefine healthcare. We've all mentioned and seen and witnessed how 2020 is a pivotal year on so many different levels. And I think there's a lot of opportunity there. You know, if we can go from 0 to 100 with telehealth, like overnight when we have to, I think anything is possible. And I really think that, you know, you all as our Jedis now, you know, we expect nothing but greatness from all of you. And we really invite you all to think about, you know, the discussions that we had today, and think about, you know, what's one thing that you might want to impact based on some of the conversations that we've had today. Because, you know, I'm seeing like 100 people on this call, and there's so much collective power in that, in our respective organizations and as healthcare leaders. So our call to action is to really think about how you might, you know, incorporate some of this into your work life, your personal life. Again, thank you so much to our panelists for sharing all your insights. Thanks to everyone who attended. And I'm going to hand it back over to Sarah, who's going to close us out.
Thank you so much, Ida, Efton, Anna, Kelly, and Carla. This was a wonderful discussion. I think we could have easily gone another hour and still not exhausted the topic. We really appreciate everyone staying on a bit longer. Please continue to submit your questions. We are absolutely taking those down and plan to address them in writing following this panel. As I mentioned earlier, this session will be recorded and available to you on the CAHL website in a few days. You will receive a link, not only for this video, but also for a survey evaluation in your emails Your feedback is absolutely important to us. This is the first of our series, and so in fact, it's even more important now so that we can continue to improve and deliver really rich content to you in the coming months and weeks. Really appreciate all of your time. I hope you have a wonderful evening and weekend. Everyone stay safe. Thank you.